All right. Hello, everybody. Thank you. And thanks for joining us again. So I'm happy to introduce Dr. Namrata Setia. She's an associate professor of pathology at the University of Chicago, where she serves as section chief of gastrointestinal pathology division and director of the gastrointestinal and liver pathology fellowship. She's board certified in anatomic and clinical pathology with fellowship training at Massachusetts General Hospital and the University of Chicago. She's recognized internationally for expertise in gastric pathology and contributions to the WHO classification of digestive system tumors. Her research bridges gastrointestinal and molecular pathology. She is an active leader in national and international pathology societies. And thank you, Dr. Setia, for joining us.
Thank you very much for this opportunity by GIPS and also by PathCast. It's a great pleasure to be here and talk about the differential diagnosis of gastric carcinoma, which ties in so nicely with the morphologic spectrum of gastric cancer. Just because the spectrum of gastric cancer is so diverse, I feel like all of us who like morphology end up falling in love with gastric cancer. But then it also creates its own kind of challenges, especially because gastric cancer can be excessively subtle. And not only that, it also lacks lineage-specific immunohistochemical markers, which adds another layer of complexity to this topic. But what is really helpful is that the challenges or the differential diagnoses that we talk about with each gastric cancer subtype are unique to that exact subtype. So what I mean to say is poorly cohesive signaturing cell gastric cancer will have a different set of differential diagnosis from tubular moderately differentiated gastric adenocarcinoma. And what that ends up being is that the challenges kind of almost fall in parallel with the classification of gastric cancer. So this session is actually divided into 4 different subsections, each of which kind of follows or lines up with the gastric cancer classification. So starting out with the first WHO category, that is the polycohesive carcinoma signaturing cell phenotype. I like to call this the double mimic. It's because the cancer cells tend to be very subtle. They don't declare themselves like other cancers, but once you learn to appreciate them, then you also start seeing these benign mimics that if you're not careful, you can end up overcalling a lot of entities. So let's start out by defining what a classic signaturing cell carcinoma or signaturing cell is. And this comes from individuals who are carriers of pathogenic or likely pathogenic variants in CDH1 gene. I highly recommend reading this consensus paper on pathologic definitions and classification of polycohesive gastric cancer. It's co-authored by Professors Carnero and Wheat, who are speakers in this conference. And topic 1 of this paper is definition of signaturing cell carcinoma, or signaturing cells actually, which the authors define as cell with ample cytoplasmic mucin, which appears optically clear on H&E staining and has eccentrically placed nucleus like we can see here. So this is an example of a classic scenario, prophylactic gastrectomy from a 37-year-old male who was a CDH1 carrier. As Dr. Furt mentioned, most of these specimens look almost normal on an gross examination as well as endoscopy. And histopathologic examination, it requires a trained eye because these foci can be extremely subtle. I hope you can appreciate the signaturing cells over here, but they are often limited to the superficial mucosa. They're present singly or in loose clusters, often infiltrating between or displacing the glands. They're seen in the auxentic type mucosa, and that was the rationale for Dr. Furt mentioning that a proximal portion of the stomach to be submitted for examination in CDH1 gastrectomies. But importantly, there is also no background gastric dysplasia seen in the mucosa. Nowadays, we are facing a new challenge, and that is the task of identifying these foci and gastric biopsies from patients who are CDH1 carriers, but they're postponing their prophylactic gastrectomies. And these specimens are even more challenging, not just because these foci are so subtle in the appearance and size, as we can see over here, but also because the usual histology processing artifacts such as tissue folds, as we can see excessively in this biopsy, they can easily obscure these smaller scan foci of signature cell cancer. An approach that has been advocated is using PS stain instead of H&E stain, especially by Professor Carnero and group, is and what doing PS stain helps with is it stains the signature cells magenta in color and provides a contrast with PS negative lamina propria. So ends up reducing the screening time and also the chance of missing these foci. So now let's flip the coin and see the other side of it. So let's consider the question that was raised by topic 2 of the consensus guidelines. That is, are all cells with signature cell morphology necessarily malignant? And of course, the answer is going to be no. But going through the first benign mimic, which has been the best classified, but still less well recognized, is a glassy cell change. This is a change that is seen in the gastric antral pyloric mucosa and also in Brunner's glands, as you can see here. And here the glands are lined by mucus-secreting cells, but these cells have an eccentrically placed nucleus and a faintly homogeneous, homogeneous, faintly eosinophilic cytoplasm, which looks ground glass in appearance. These are not Hep B infected cells. They're also not glycogen rich, as is confirmed by the negative PS stain over here. The reticulin stain highlights that these cells are confined to the basement membrane. So this change was actually described way back in 1980s, and this is one of the early studies describing it, not just by morphology, but also by electron microscopy. And what the authors determined was that this change is because of a cytoplasmic vacuole. And they described 2 morphologic appearances associated with it, that is type 1 and type 2. Type 1 was always associated with some degree of eosinophilia and ground glass cytoplasm, and type 2 was strikingly clear. Electron microscopy performed at the time confirmed that the change was because of that cytoplasmic vacuole, which was pushing the mucin granules and the nuclei towards the upwards or towards the lumen in this case. What the authors kind of proposed was that this vacuole was derived from endoplasmic reticulum and Golgi apparatus and is likely present because of a defect in mucin glycoprotein synthesis because of accumulation of non-glycoconjugated core proteins. This change has also been described in hydrogen potassium ATPase deficient mice, as well as in baboon stomach, especially in a relatively high frequency. One thing to consider is that the protein, the ATP4A protein, is actually expressed in the parietal cells, but the change is often seen in the mucus secreting cells. So that discordance definitely makes you pause. So moving on to the second benign mimic, this is a very distinctive change that is seen in a very specific circumstance, that is resection specimens obtained from patients who have, or the resection specimens were performed for toxic ischemic injury. In this case, the patient underwent a gastric wedge resection for gunshot wound injury. And what you can see are these signature-like cells, which are floating in the lumen towards the mucosal surface. But going deep into the mucosa, where it's more intact, you can see that these cells are falling off the basement membrane and also detaching from each other, but they're still confined to the glandular structures. So this change has been reported in the literature as benign signaturing cell change or pseudo signaturing cell change. This is a case report published in 2011 from Dr. Liu and colleagues in AJSP, where they describe something which was very similar from what we saw, that the signaturing cells were detached from the basement membrane and from each other and freely floating within the tubular structures. In their case, the specimen was a total gastrectomy, which was performed for perforated gastric ulcer. They also performed other stains such as PASD and A1, A3 to characterize these cells. But I think what was most important was a reticulin stain confirmed that these cells were confined to the basement membrane. Additionally, they performed E-cadherin and P53, which showed a non-aberrant expression confirming that these were pseudo-signaturing cells rather than true signaturing cells. So similar changes, of course, have been reported in other resections, not just gastric, but also in the other parts of GI tract, such as colon and C. difficile colitis, as well as in gallbladder with ischemic colitis and Peutz-Jeghers polyps. So a potential pitfall here is that these cells actually may be mitotically active and may show high Ki67 labeling index. So it's very important to not use these parameters to assess benignity. The third benign mimic that we can talk about in this instance is a gastric xanthoma. These are often small, yellowish, pale nodules or polyps less than 3 millimeters in size. And histologically, you can see them as these lipid-laden macrophages, which are not just present in the lamina propria, but sometimes even in the submucosa. Interestingly, they have no correlation with hypercholesterolemia, and often they have minimal clinical significance, except that they can be misread as significant cell adenocarcinoma. And sometimes it's really not that easy. And just to demonstrate that, let me share an example that we had in-house. This patient was 37-year-old with fleshy skin bumps on torso, arms, and scalp. And the PCP actually told him that these were lipomas. On biopsy, they of course do look like histiocytes, but on additional workup, these were confirmed to be metastatic signaturing cell adenocarcinoma. An EGD performed 1 week later showed a mass in the gastric body, which on biopsy was of course confirmed to be polycohesive carcinoma signaturing cell type. There are subtle morphologic cues to make that differential. One is, of course, the quality of the cytoplasm. In xanthoma, it tends to be more foamy compared to more granular and mucin-like in signaturing cell carcinoma. And of course, you can see some clustering with the carcinoma compared to sheet-like architecture, which is present in the xanthoma. But given the gravity of the implications of the clinical diagnosis, I think performing IHCs in cases where there is diagnostic uncertainty is definitely essential. So this is a table for our first category, which summarizes the challenges and also the diagnostic clues and aids with our first category of WHO classification, that is polycohesive carcinoma signaturing cell type. Moving on to the second one, which is still polycohesive carcinoma, but the other cell type. I find this tumor very unsettling because it literally goes against everything that we have been taught about what cancer can look like on H&E stain slides. So let me share a couple of examples here. So this is an EMR specimen performed for a gastric body lesion in a 71-year-old with autoimmune gastritis. And at this low power, you can appreciate that there's clearly atrophic gastritis, which could be consistent with autoimmune gastritis. But at low power, you don't see any abnormal clusters or effacement of normal or metaplastic glands, and definitely no stromal reaction. Zooming in, you still can't pick out the tumor cells. Zooming in further, yes, you do appreciate some atypical looking cells with irregular nuclei, but they're not much hyperchromatic than the background. And even in terms of size, they are very comparable to an adjacent plasma cell that we can clearly identify. But if you do a keratin stain, you can appreciate the number of tumor cells that were just hiding in plain sight. And the other instance where we get routinely challenged to identify these cells are peritoneal samples that are obtained during exploratory laparotomy. And even when you're looking at these cells, you can't really recognize them, although they're right in front of you. But doing a CDX2 stain in this case was very helpful in picking out the tumor cells. And a pitfall here is that if you do A1, A3 like we did previously, or CK7, it's not really going to be helpful because it will also stain the mesothelial cells. Doing Claudin-4, BRIP4, MARC31 are other useful aids, especially in cytology specimens where the reactive mesothelial cells can look like carcinoma cells. So I hope I was able to convey with these cases that we need to have a low index of suspicion and utilize IHCs as appropriate to confirm the presence of absence of carcinoma. Even when these cells are obvious, it's very difficult to classify them as carcinoma, let alone gastric carcinoma. And that's why we have this second part of topic 2 of the consensus statement. We really need to have a broad differential. The closest mimic in this instance tends to be this type of tumor, which is present in the superficial lamina propria. The cells are discohesive, but hopefully you can appreciate a little bit of single file appearance. They are monomorphic, but there's also targetoid mucin in them. These stained with ER, GATA3, and A1A3, consistent with metastatic lobular breast cancer. Of course, if they lack the estrogen receptor GATA3 expression, that can be really challenging. And that was really the focus of the study that was performed by Dr. Patil and colleagues. And some of the findings that they found were really unsettling. One of them was 10% of patients did not have a history of lobular breast cancer or readily available history. And then the average time between the initial diagnosis and METS was 7 years, with the range spanning all the way to 36 years. 4 patients were actually negative for both ER as well as GATA3. And diffuse full thickness involvement was one of the most helpful features that was seen with diffuse type gastric cancer, besides anastomosing architecture or pleomorphic enlarged nuclei. On the other hand, metastatic lobular breast cancer showed a single file appearance as well as superficial lamina propria involvement, like we just saw. But in the absence of mucin and that clinical context, I think we need to open up the differential a bit wider, as seen in this undifferentiated cell infiltrate, which actually was read as gastric cancer when these biopsies came in. But opening up the IHC profile and also consulting the hempath colleagues, this case ended up being involvement by aggressive plasma cell neoplasm that the patient had a history of. This is an example of another undifferentiated infiltrate. If you're lucky, you can find some pigment here, and that would correspond to involvement with malignant melanoma. GI tract involvement by malignant melanoma often presents with very non-specific signs, like was in this case, the patient actually was getting immune checkpoint therapy for melanoma, and the biopsies were done to rule out immune checkpoint therapy, which was also present besides involvement by melanoma. A melanoma involvement by GI tract is not uncommon. It actually has been reported in about half of the cohort in this study, where gastric involvement was seen in about a quarter of the cases. This was an autopsy study of over 200 patients, but another key point that they found was that advanced melanoma always involve multiple organs, meaning that gastric-only involvement would be rare. Having said that, there are case reports of gastric-only involvement, and so it's uncommon, but not impossible. Without going into the details of the IHC markers, and just touching on the one that is the newer kid on the block, that is PRAME, or preferentially expressed in melanoma. It has the best sensitivity, apparently, but the specificity is not that great. But most importantly, PRAME expression is infrequent in GI tract cancers, and this is coming from a study of more than 5,800 epithelial and non-epithelial tumors. And what the authors found was that none of the 56 stained gastric cancers were positive for PRAME. So that looks very optimistic in terms of markers to rule out melanoma. Overcall is typically not a problem in these cases. One of the cases that is, or one of the case reports that's out there by Dr. Aronson and Lowers talks about this patient who had these two patients who had non-specific symptoms and no concern. for cancer, but then on random biopsies, there were these detached mucosal fragments that showed morphology of poorly cohesive carcinoma. And not just that, they also had high Ki-67 proliferative index, which prompted the consult. The points that were helpful in making the diagnoses were that the surrounding mucosa with the epithelial cells showed clusters within the glandular lumina, like seen here and here, which was suggested by epithelial extrusion rather than true invasion. And Ki-67 was not just increased in the detached cells, but also in these extruded cells, as well as in the mucous neck cells. And also a keratin stain performed at the same time showed no single cell invasion in the lamina propria, again favoring that this is a benign proliferation and not really a malignant proliferation. So again, here is a flow chart, a table sort of highlighting all the challenges and the aids that we discussed, hopefully conveying to you that we need to have a low threshold of suspicion, a broad set of differential, and also be aware of the benign mimics for this subtype of gastric cancer. Moving on to the next type, papillary tubular and mucinous. For these type of cancers, the real challenge is not really identifying them as gastric cancers, but really proving that these are gastric in origin. So most of us start out with a panel that includes CK7 and 20 for adenocarcinoma of unknown primary. And while 70% of gastric cancers are 7 positive and 20 negative, it is important to remember that all other combinations can be present in gastric carcinoma. So what I'm trying to say is that the reliance on the cytokeratin profile is really insufficient for identifying the stomach as a primary site of origin. Since stomach lacks the lineage-specific markers, most of us always include a panel of rule-out markers, which are transcription factors. And the issue with using these markers is that they can show this stochastic upregulation, meaning they can be randomly expressed in cells of or tumors of other cell lineages. And of course, if you rely heavily on those markers, this can lead to misdiagnosis. So let's go through some of the commonly used ones. Let's start out with TTF1 and napsin A. So this was a study which was performed on 854 samples of GI tumors, including esophageal, gastric, and colon adenocarcinomas. And what they found was 2 out of 419 cancers of gastric origin expressed TTF1 and 4 expressed napsin A. And of the 5 that co-expressed TTF1 and napsin A, 2 were of gastric origin. It seems like this co-expression may be selective to a specific subtype of gastric cancer, but there's more data to follow on that aspect. The other important rule-out marker that we use in clinical practice is GATA3, and we use this as a marker to confirm breast or urothelial lineages. In this large study of 2,500 epithelial and non-epithelial tumors, the authors found that GATA3 was expressed in 5% of gastric cancers. Most of the times it was focal in terms of expression, but one case did show diffuse expression. And importantly, all gastric signature cell carcinomas were negative, which would be pertinent to our prior discussion. And building on the same theme of lineage markers showing unexpected expression, NKX 3.1 is a sort of a well-regarded marker for prostatic adenocarcinoma with high sensitivity and specificity. Although we do know a bunch of non-prostatic markers that can express NKX 3.1, now esophageal and gastroesophageal adenocarcinomas have joined the list, showing focal, strong, and diffuse positivity in a varying number of cases. In their study, it accounted to 12% of the cases, with one case showing a strong diffuse positivity. So what I'm trying to say over here is for this subset of gastric cancers in terms of differential diagnosis, using CK7 and 20 and the rule-out approach is still fraught with pitfalls, and then we need a comprehensive diagnostic approach which includes clinical and imaging context besides morphology and IHC to get to the diagnosis. And finally, coming on to the last section of this session, the underappreciated entities. I highlight these because these often get called as poorly differentiated adenocarcinomas, but these are unique entities in their own self. The ones that I'm talking about are carcinoma with lymphoid stroma and undifferentiated carcinoma. They are uncommon but not rare. They sound similar, but they are actually prognostically opposite. So let's take a look through them. So a carcinoma with lymphoid stroma is often associated or driven by EBV. And both these entities, the common thing is that they have undifferentiated cells and they can show increased PD-L1 expression. But these and several other entities have shown that carcinoma with lymphoid stroma is associated with better prognosis, whereas undifferentiated carcinoma is associated with worse prognosis. The other important point is that carcinoma with lymphoid stroma is associated or is immune hot, which means it has abundant tumor infiltrating lymphocytes, whereas undifferentiated carcinoma is immune cold, which means that it has minimal infiltrate of the lymphoid cells. And here's a beautiful example of carcinoma with lymphoid stroma shared with me by my senior mentor and colleague, Dr. John Hurt. We can see these tumor cells, islands of tumor cells that are almost overrun and nearly obscured by lymphocytes. A pitfall here to remember is CK7 can be negative. In fact, it is negative in more than 90% of these cases per this study. Immunostain for broad spectrum keratin can help, but even better is using an EBER-ish, which would highlight these tumor cells and also help in establishing the diagnosis. Undifferentiated carcinoma is, of course, undifferentiated cells without any cytologic or architectural distortion, but importantly, no immune cell infiltration. A pitfall is, of course, calling it poorly differentiated carcinoma. What can help is an immunostain for INI1, which would correspond to SMARCB1 loss, or BRG1, which would correspond to SMARCA4 loss. I feel like we have become much better at diagnosing these entities now than we were in the past, where we use NGS as a clue to do the IHCs. But one thing that I would highlight is that when you have missense variants, missense pathogenic variants in these genes, you may still have retained expression of the protein, but the biology and the morphology would still be of undifferentiated carcinoma. So here's a table summarizing the similarities and the differences besides the pitfalls and the aids. But one thing to be certain is, like, please don't call them poorly differentiated carcinoma, because these are unique entities with their own prognostic significance. So this finally ties up the 4 points that I discussed, which ties in with the morphologic spectrum. Thank you very much. And I don't think I left too much time for questions.
Thank you, Dr. Setia, for that great talk. Yeah, we're about out of time, but we've made note of all the questions and we might be able to post responses to them accordingly. But I think we'll probably move on to our next speaker, but really great talk.
Thank you. I apologize for taking over all the time for the questions.